I was previously the public health officer for Butte County. Some of this work started at that time, but is continued. And so what I'm going to talk about today is the effects of smoking in Butte County. And there'll be a few questions that I'll ask now and others that we'll ask through the course of the presentation. But the first question is, what if our smoking rates in Butte County matched California's? What would we expect that to do to our cancer rates? And we've done some data modeling to try to look at the contribution of smoking to our some cancer rates and some other things, and then talk about some things we could do to improve. So just so I know that you can still hear me and I haven't gone away, can you still hear me? Yes, I see nods, so I will move forward. So when I was at the county, a couple of GI doctors called me and they said, we think we have higher cancer rates, specifically colon cancer rates in Butte County than in California. Why is that? And so that question really launched a lot of the work that you're about to see. And the fact that I've titled this Smoking and Cancer kind of gives away a hint that smoking is suggested to be a great part of why we have higher cancer rates. And I will talk through that as we go, but the question, why is Butte County have higher cancer rate? Well, we need first to ascertain that we do have higher cancer rates. And so this busy slide with lots of numbers, as Natalie suggests, looks at that. And so in the first column, it is the incidence rate of certain cancers in California. And an incident rate is the number of new cases per 100,000 people per year. And so we use rates like that rather than absolute numbers so that we can compare different populations, different counties. We can compare Butte County to California. And here are the incident rates in Butte County for those same cancers and some other things. And if they are in red, that number is higher. And if there are cancer incidence rates are lower, it's in blue. And you see that for most cancers, with the exception of kidney, liver, and stomach cancer, Butte County has a higher rate. And if you take them all over on the right-hand side, this is the percentage difference. And down on this all cancer number, it suggests that we have a 14% higher rate of cancers in Butte County than in California. And we also have a 16% higher all-cause mortality rate in Butte County than in California. So it appears to be true that what the GI docs were asking, both for colon cancer, which we have a 12% higher rate, and really cancers overall. And so the question is, why might that be? And we will go on and try to talk about at least one potential contribution to that. So the question was brought up that smoking might be a contributing part of this. And so we asked the question, what would we expect our cancer rates to be in Butte County if our smoking rate was not higher, but it were the same? And I will give you some smoking rate numbers in a little bit. What might our cancer rates look like? And so you should know some background things about tobacco and nicotine in the US and in California. So a little bit of background information. Tobacco is the leading cause of preventable death in the United States. We know that it causes about 500,000 or 500,000 deaths a year in the United States alone, leading it to be the leading cause of preventable death. Someone who is a current smoker has nearly 3 times the mortality rate as someone who has never smoked. And that on average, smokers' lives are about 10 years shorter than non-smokers. So this is all data that we've known for some time. And moving away from just the effect on life and suffering, the cost to California alone, the numbers are above for the US, but the cost to California is over $13 billion a year. And in fact, each one of us pays about $600 a year to try to help provide the care and the medical expenses for smokers, whether we smoke or not. So it costs us all a significant amount of money. Now I threw this slide together today, so forgive me for the fact that it looks like something you do in junior high school and it's all twisted, but it's right out of a book that I use in a class I teach at Chico State. And it kind of gives you the history of smoking in the United States. In 1900, smoking was very, very uncommon, smoking cigarettes. And this is about cigarette consumption. And not surprisingly, the lung cancer was a very uncommon cancer. There are some interesting articles in the Journal of the American Medical Association from early in the 20th century that talked about the rare case of lung cancer. But as you see, smoking increased, and then in the time of World War I and in World War II increased dramatically. Cigarettes were provided to soldiers at no cost, and it was very common for soldiers to smoke. Another interesting thing is that economics affect the consumption of cigarettes. When people had less disposable income during the Depression, cigarette use went down. And that's something that you will see in legislation in California. When cigarettes become more expensive, their use decreases. So cigarette use in the United States peaked right about 1965, at which point about 40% of people were smokers. And the good news is that smoking has decreased since 1965 for a number of reasons, down to this chart goes to about 2012, when the percentage was significantly lower, and I'll show you another slide. Now, this is a slide that talks about a number of things that happened when the Surgeon General report came out, both for the use of with smoking and secondhand smoking. But I want to throw out some credit to the state of California, who is a leader both in the US and in the world on decreasing smoking. Back in November of 1988, California passed Proposition 99 that added a 25-cent tax per pack of cigarettes to cigarettes, used some of that money to put together tobacco control efforts, and used other of that money over the years to support First 5 efforts, which are health and wellness for children 0 to 5. Now, that Proposition 99 has been looked at as one of the most successful public health campaigns in the world in the last 100 years for a number of reasons. And it's a model that has propagated throughout the United States and throughout much of the developed world. In 1995, California was the first state to ban smoking in restaurants. And that was a politically difficult thing to do, as people thought that use of restaurants would go down. It did not. In 1998, California passed legislation banning smoking in bars. Difficult to do because bars said that they would decrease in their clientele and their profits. It did not. In 2016, we passed Proposition 56, which put a $2 a pack tax on cigarettes, which funded public health efforts to decrease smoking and was also very effective. And it's those kind of things, in addition to other work that you see on this slide, that has decreased the tobacco and nicotine dependence in our country. Interestingly, just less than a month ago in California, we passed Proposition 31, which upheld the statewide law barring the sale of flavored tobacco, with nearly 64% of people voting for it. And if you were to ask me how important I thought that was, if we had more time, I would go into it and just say it is very important. So a little bit of history. This slide kind of shows the same thing, a peak in 65 in the US at a little above 40%, 42.4%, and a decrease in the United States about to 14%. Interestingly, you see the red graph, which is youth smoking, and a downturn after 2015. Unfortunately, that downturn may not be as optimistic as it initially appears, in that that's because this is cigarette use and not e-cigarette use. And likely what happened is that youth started using e-cigarettes and used cigarettes less. And depending on who you are, that might be good news or bad news. I would suggest it is mostly not good news. But I want to start with this because most of these last two slides are good news. And we need to celebrate the successes and what got us here so that we protect it and continue, because there is no guarantee that our progress in this area will be the same going forward. There is nothing written in the universe that says that this progress continues without the effort of many people over a long period of time. So that's the good news. Smoking is down. But it is not down low enough. And here's a map on the left of cigarette smoking in the United States in 2016. And you can see where it is darker, there is more smoking, and where it's lighter, there is less. Interesting, although not by any means conclusive, is the map on the right, which shows colon and rectal cancer incidence in the United States. I don't think it takes too long looking back and forth to realize that there are correlations between these two. And this kind of map and mapping create a hypothesis for us. This is by no means proof. You could say that colon cancer and smoking both follow poverty, for instance, and that there isn't a causal relationship between smoking and cancer. And so you have to prove that. But it does lead us to ask the question, could there be a relationship between these? And what is that relationship? And so trying to answer that question, we took these inputs and created some data modeling. If we have the following information, and this is an example, the smoking rate in Butte County, which is approximately 17%, some numbers have it higher, some lower. It's higher for men than women, for instance, and there are differences, but overall about 17%. Excuse me. The California smoking rate is around 11%. Well, if we take that information and we combine it with things that we know, like Butte County's incidence rates for a cancer like colon cancer, and California's incidence rate for a cancer like colon cancer, and we have one more piece of information, and that's something called the relative risk. So the relative risk is really just the risk of developing something based on having an exposure. So the risk of developing colon cancer when you are a smoker versus a non-smoker. And in this case, the number of 1.27 means that, for instance, every 100 non-smokers that would develop colon cancer, we would expect 127 smokers in the same of the same number to develop it. So an increased risk of about 27% of developing colon cancer if you are a smoker. And so taking information from different cancers and different published data in the medical literature about relative risk, I got together with Dr. Jane Go from Chico State's Biostatistics Department, and we modeled these next set of slides that I want to share with you. That's the formula. I won't bore you with it because somebody really would cut me off then. So I'm going to take a little bit of time with this slide because we're going to look at these slides over and over again, and in the future they will go much more quickly. So this is looking at the relationship between breast cancer and smoking. And this is the incidence rate, or the number of cases in Butte County every year. Okay, so we have about 150 cases of breast cancer in Butte County every single year, based on our incidence rate and based on our population. The next line is how many cases of breast cancer we would expect in Butte County if we had California's breast cancer rate rather than Butte County's. And that number is lower. The difference is this number, 15.13, suggesting that we have, because of a higher incidence rate, about 15 more cases of breast cancer in Butte County every year than we would have if we had California's rate. And using that data modeling, the most important number is this 9.16. Our data modeling suggests that of those 15 extra or additional cases, 9 of them can be statistically connected to smoking. So hopefully that made sense. Number of cases every year, the number of cases that we would expect if we have the better rate that California has, what the difference is, and what of those difference can be attributed, not attributed, but associated with smoking. And that's about 61% of the excess cases of breast cancer are associated with the increased risk of smoking. Let's move through the next slides more quickly. If anybody has a question, just raise your hand, or I don't know if you can unmute yourself, but do it and yell at me and slow me down, because I'm going to move fast now, because each one of these is the same data modeling. This is bladder cancer, and you may or may not know it, but the greatest risk factor by far of developing bladder cancer is smoking. And so it suggests we have 10 more cases of bladder cancer than we would with California's rate, 7 of them attributable to smoking. About 70% of the additional cases of, not all cases, but the additional cases of bladder cancer we can associate with smoking. Moving forward, cervical cancer, 78% of excess cervical, not all cervical cancer, excess cervical cancer can be associated to smoking. Colorectal cancer, 60% of the excess cases. Esophageal cancer, 45% of the excess cases. Of esophageal cancer not in current smokers, but former smokers, 33%. Laryngeal cancer, almost 75%. Lung cancer, and this is an important one, because this starts to validate our data modeling, because we would expect that almost 100% of excess cases of lung cancer really should be due to excess smoking. And in fact, that's what it shows, right? So, and this is what we would expect. The main risk factor for lung cancer, based on the differences we saw in 1900 and we've seen since, is smoking. Pancreatic cancer, 100%. And it goes on. And not just cancer, but cardiovascular deaths. So this is cardiovascular deaths in women. We would expect that we have, based on our cardiovascular death rates, we would expect over 200 deaths. The other were just cases of cancer, not deaths due to cancer. Now these are deaths due to cardiovascular disease. About 205 women every year, which is higher than what we'd expect if we had the state rate, about 25 cases, and 75% or so of that we can statistically associate with smoking. In men, about 54%. So all of this, overall mortality, most of it due to smoking. Overall mortality in women, most of it due to smoking. So I'm going to move forward out of these slides now and just say, so this data modeling starts to suggest to us how important smoking and increased smoking rates could be to the development or the risk factors for cancer and cardiovascular disease and all-cause mortality. So that starts to tell us, even though we're tired of talking about smoking, it's still important. It still is a major risk factor. It still kills way too many people in our world, in our country, in our state, and in our county. Now, I want to caution myself and your conclusions that you could draw from this to remind us all that we cannot prove causation from these kind of statistics. They are correlations, and so they suggest, but they do not prove. And that any change in smoking locally could take many years to see the ultimate impact. And yet, changes we make in people starting smoking will have an enormous impact, and that's why the flavored tobacco ban is so important. So those are limitations to that data. So I'm going to move now to another question that was asked when I started at Enloe by an oncologist at the Cancer Center. And they said, in Butte County, we tend to diagnose cancer at a later stage than the California average. Now, that's a whole different question with a whole different set of reasons why it might be true. It is true that we do, on average, diagnose cancer in later stages in Butte County than in California as a whole, which is not an uncommon problem in more rural counties. But it doesn't take too long in medicine to realize that the main reason is that we have screening opportunities for cancer that we miss. And the more rural we are, the more likely we are to miss those. So I'm going to come back to that in a bit, but really the way to diagnose cancers at an early stage is to increase our screening. And when it comes to tobacco and the screening we should be doing, I'm going to either remind you or likely tell you for the first time ever that you may not know that there is a screening test for lung cancer, just like there's a screening test for breast cancer, mammograms, and colon cancer, colonoscopies, or other studies. And you know about those and you hear about them, but you may not have heard that there is a screening test for lung cancer, and it is recommended by the most important organization. It's the one that if they recommend it as an A or B recommendation, most all insurance companies need to cover it. And so this is a covered benefit for almost everyone. And it says that if you are 50 to 80 years of age and have a 20-year pack history, which means you smoked a pack a day for 20 years, or 2 packs a day for 10 years, or a half a pack a day for 40 years, and haven't quit within the last 15 years, you should have an annual, every year, low-dose CT scan to screen you for lung cancer. Despite the fact that this has been a recommendation for a number of years, only 4.5% of people that meet this criteria in the United States get this study. And our federal government's Healthy People 2030 goal is not that we will get up to 50%, but that we will just get to 7.5% by 2030. And so the answer to the question specifically about lung cancer is, how can we diagnose these at an earlier, more treatable stage, is to do this screening. And so what have we done at Enloe? So in the last little over a year, we've created a nicotine or tobacco cessation program. We started by asking all of our clinics to be reminded by our electronic health record system for people who have not been asked about nicotine or tobacco use in the last 6 months. If they've not been asked, ask those questions and record the answers in our electronic health record, and ask them 2 questions. Would you like to quit? And would you like help? So if the answer to those questions is yes, then people are referred to our tobacco cessation counselor at no cost to them. And so I will describe so for those of you that go to your medical appointments and you get asked lots of questions, it was important to us that you not be asked this question every single time. Like if you went in for wound care 3 times a week, you're not being asked it every time you went in, but just once every 6 months, somewhere in the Enloe system. So not at each different office even. So if that referral is made to our nicotine cessation person, she will contact the person that is the smoker and offer lots of support. Her expertise, which she is a certified tobacco cessation counselor, she will follow them for at least a year if those people want. She will give them advice and counsel them through their efforts to cease. If they would benefit from medications, she will talk to me and I will call them on the phone and talk about whether it's responsible to give them those proven medications. We will contact their primary if they have a primary provider and let them know what we're doing and offer that primary the opportunity to provide those medications. And so an effort to try to help people who want to quit, because it is a difficult thing to do. There may be people on this Zoom that have tried and could provide their own experience on how difficult it can be. The other thing that does is that provides us an opportunity to evaluate those people and see if they should be getting those annual low-dose CT scans as a screening for lung cancer. And so we get to do that in 2 ways. Our nicotine cessation person can do that while they're talking to them, but realize we're also recording that information for all people in the Enloe system. And so we have a report we can run that says, these are all the people that meet the criteria to have the annual screening, but that have not had it. And the most recent number for that are 2,300 people in our NLO system that should have that screening and have not. And you should know that last year, we only did about 160 of those scans the whole year. So that shows how vastly underutilized that recommended and paid for screening exam is. So that brings to an end my kind of formal discussion. What I wanted to do is cover some statistics about smoking, a little bit of history. I wanted to describe to you some of the work that we did to try to answer those physicians' questions and to try to model the potential impact of tobacco on our community and its cancer and cardiovascular disease rates, and also some efforts to try to address that for those people with the screening, the nicotine cessation navigator, and the identification of those who are due for screening or would benefit from screening, so that we can more proactively offer that to them. And hopefully, for those unfortunate people that will develop lung cancer, have it be caught at an earlier, more treatable stage. So I think what I was told originally is try to have about a 30-minute presentation. I tried to go fast, maybe too fast, because with me cutting out, it may have been shorter than it needed to be. But at this point, I would happily stop and open up for questions and clarifications.
Dr. Miller, do you have any idea why the percentage of people that get the screening is so low? Do they not know about it? Do they refuse it?
Yeah, I have opinions. One of them is that that there hasn't been the mobilization yet of those people that you see in mammograms and now even in colon cancer to make it an issue, put it on billboards. The truth of the matter is there are certain behaviors in our society that we are more or less forgiving of. We are more forgiving of people that develop breast cancer because we don't think they deserve it, or colon cancer because we don't think they deserve it. But unfortunately, there are some things that we are less forgiving of, and it may well be that there is less of a push and there is less likely to be a group of activists in the space, because either those people that suffer from lung cancer or our larger society may not be as forgiving for something that we consider to be a choice. We see that over and over again in lots of things. And what I would say to that is, well, we don't stop treating people with diabetes. We don't stop treating most of us who don't exercise or eat as exactly as we should. So that's one reason. Clinicians also may be less likely to order it because CT scans have radiation and there is an exposure from that. But that's the reason for the low dose rather than the normal dose CT scan. It has taken longer for medical folks to come on board with this, but realize the US Preventative Task Force takes into account not only those cancers that could be found, but the potential harm from the screening. And so they take that into account when they make this recommendation that it be done. And that's why it's the best organization to use for screening advice, better even, despite their good intentions, in my opinion, than the American Cancer Society, than the OBGYN Society, than the urologist when it comes to prostate cancer, because they have to factor in not just how many cancers you're going to find, but is it how much damage is done by screening as well? How many prostates do we take out that we didn't need to, and that kind of thing. But that's an ongoing debate always. So those are some thoughts about why it's not as common, but my hope is that that's going to change.
What about secondhand smoke for adults who lived with two parents that were smoking? Should they be concerned about this 40 years later?
I think that it is probable that one's relative risk, and we can find that, and they have found that the relative risk for someone exposed to secondhand smoke is higher than someone who was not exposed to secondhand smoke. That risk, both logically and mathematically, is lower than if you were a smoker.
Mhm.
So your risk is higher than somebody who didn't have that exposure, but lower than smokers. And if I can find published, validated relative risk data for secondhand smoke, which I think we can, all I'd have to do is plug it into our spreadsheets and they produce those slides, and we could give this similar kind of information.
So, because my father only smoked for a few years, but as you mentioned, World War II, you didn't get a break unless you smoked.
That's right.
If you smoked, you got a break. So, that was a goal.
And that ethic is not gone. There are still people who now, like if you work in the hospital and you smoke, the hospital is a smoke-free campus. So you have to walk about a block off campus to smoke. So when you take a break, you go for a walk and you maybe take longer. It's still, even in a smaller way, still out there in lots of places.
By the way, this was much more interesting because I thought we all know that smoking and cancer go together, but this was really interesting. And Butte County has a higher cancer rate in so many things. Sometimes they say the high power lines may be a factor.
Yeah, so when I first tried to answer this question, I started from square one. I looked at things that showed pesticide use in California and tried to see if I could correlate the two. I could not. Now, that doesn't mean that I was able to answer all the questions related to that. I was not able to find another kind of predictor. I think we do have a higher poverty rate, and I think there are a number of things that can indirectly connect poverty to higher cancer rates. Smoking is one of them. Diet is one of them. Lack of exercise is another one. Exposure, people that are poorer tend to live in places that they are exposed to more chemical agents in general, more air pollution, for instance. But this is the one I found that I said, if we could do one thing, boy, it sure seems like it would do a lot. And I want to give credit to the state of California and the voters of California who continue to do the hard work to try to improve those numbers.
Thank you.
Thank you. Any other questions, comments, criticisms, suggestions for improvement? I'll just say this, that part of the reason to go through and show so many different types of cancer and things like cardiovascular disease is that we knew we were going to be going to all of our specialists and saying, we want your medical assistants to take the time once every 6 months, anywhere in the organization, to collect this data. And their lives are busy and their clinics are busy and their time is short. And so we have to make a case for why it's important. And if I can go to a urologist and show how smoking affects bladder cancer rates, it becomes important. If I can go to the cardiologist, to the pulmonologist, to the GI doctor, it makes it important to them, immediate to them, and allows them to be a part of that solution rather than opposition to the little extra that we're asking them to do.